The topic of the meeting today is on extended release medications for addiction treatment in patients with opioid use disorder. At the beginning of every CEPAC meeting, we ask our panel members to introduce themselves, talk a bit about their work. We'll begin with Stephanie.
Oh, it's already on. Okay. Good morning, everyone. My name is Stephanie Nichols. I am an associate professor at the Hudson University School of Pharmacy. I am a pharmacist by training. I specialize in psychiatry and substance use disorders, and am board certified in psych and pharmacotherapy. And I'm also an adjunct clinical assistant professor of psychiatry with Tufts University School of Medicine.
Hi, I'm Austin Fracked. I'm a health economist with the VA Boston Healthcare System. I also have affiliations with Boston University School of Public Health and the Harvard University School of Public Health.
I have to turn this on?
I think it's on.
I'm Martha Gould. I'm a senior scholar at the New York Academy of Medicine. I'm a clinician, family practitioner initially, and then a policy person who's worked in standardization of cost-effectiveness analysis methodology.
Good morning. My name is Reverend Albert Whitaker. I am with the American Diabetes Association as a region director for community health strategies.
Good morning. My name is Jason Wassman. I'm a cardiologist. I'm one of the medical directors of the Mass General Physicians Organization. I'm director of outcomes research in cardiology at the Mass General Heart Center, and I'm an assistant professor at Harvard Medical School.
I'm Ed Westrick. I'm a primary care general internist in a community health center in Rhode Island, a pharmacoeconomist in a previous life. What makes this particularly interesting to me is I have an MAT service that's been going on for a little over a year.
Good morning. I'm Claudia Gualtieri with AARP, an advisor with the Campaign for Action, a joint initiative of AARP, AARP Foundation, and Robert Wood Johnson, focusing on access to care for consumers and building a culture of health through work on social determinants of health.
Good morning. My name is Steve Cogan. I'm a professor at the College of Pharmacy at the University of Rhode Island, where I direct our graduate program in health outcomes research and a member of the Rhode Island Medicaid Drug Utilization Review Board.
Hi, I'm Claudia Gross. I'm a gastroenterologist and internist with Western Connecticut Health Network. I'm also a clinical educator with affiliation with multiple medical schools based in the GI program at Norwalk Hospital. I'm also president of the Connecticut State Medical Society and have been involved in various quality indicator and patient evaluation committees.
I'm Julia Prentis. I am a health services researcher and the research director of the Betsy Lehman Center for Patient Safety, and I also have an affiliation with Boston University School of Medicine.
Good morning. My name is Stacy Brown. I'm an associate professor at UConn School of Medicine, where I also direct the community-based education office.
Thank you. And I'm Rob Aselton, professor and chair of the Division of Behavioral Sciences and Community Health at UConn Health. Most of my work is in the area of mental health and suicide prevention and health outcomes research. At the beginning of every CEPAC meeting, we also want to ensure that all of our panel members and speakers disclose any conflict of interests with industry today at the meeting. Every member of our New England CEPAC panel who is present today has met the ICER conflict of interest policy. We'd like to ask any of our members if they would need to update their declarations at this time. Seeing none. Other speakers, including our policy roundtable participants and individuals making public comments, are also asked to disclose any conflicts of interest with industry or other potential influences on their judgment. We will present this information publicly on slides. And now I'd like to introduce Dr. Steve Pearson, president of ICER.
Thank you, Rob. Good morning, everybody, and to those of you online. So I also just want to take the opportunity to actually introduce two clinical experts who are joining the morning session as well as the later policy roundtable. They're here, and hopefully our patient representative will be able to join us soon. They're here to help serve as a resource to the CEPAC as we hear about the evidence and start to weigh it. So would I invite you gentlemen to introduce yourselves, please?
Sure. I'm Lois Nelson. I'm a professor and chair of the Department of Emergency Medicine at Rutgers New Jersey Medical School in Newark, and I oversee the New Jersey Poison Control Center as well. I'm board certified in emergency medicine, medical toxicology, and addiction medicine.
My name is Joe Wright. I'm a general internist at Boston Healthcare for the Homeless program, where I'm the director of the office-based addiction treatment program, and also involved in other kinds of low-threshold prescribing, including a care zone collaborative with MGH and the Boston Public Health Commission.
Thanks. And I'm sorry, I should have invited you also. Do you have any financial relationships with manufacturers or insurers in this area? Okay. Wonderful. All right. So why are we here today? I don't think it's any mystery. 4 years ago, ICER, we had our first New England CEPAC meeting on medication-assisted treatment for opioid addiction. And at that time already, it had become a major national crisis. New England was being particularly hard hit. Entire communities were being devastated throughout New England with a rising number of people becoming addicted and dying from their addiction. And so innovation in ways to help patients both avoid addiction and to treat addiction when it's present has been a critical need for our country. A couple of quotes related to this. Every day in the United States, more than 115 people die after overdosing on opioids. The misuse of and addiction to opioids is a serious national crisis that affects public health as well as social and economic welfare. And a patient interviewed during our initial scoping phase for this topic said, it is important that everybody has access to the entire array of treatments available, so that if one doesn't work, they will not think that this is all over. The more options they have, the better. So innovation can provide new mechanisms of action, new ways for patients and families to manage conditions. There's lots of ways that innovation can help. But new mechanisms of action and all different forms of innovation also often raise questions about appropriate use. Are there certain patients who benefit most from this kind of innovation? Are there certain new risks or new opportunities that we should be aware of? And often, innovation also raises questions about costs, about whether costs are going up or going down, whether they're sustainable, and who bears those costs, the balance between patients, families, insurers, and the rest of society. So the purpose of today is to benefit from the chance to talk through an objective look at the evidence and to weave that into a broader discussion about how we can use evidence to support clinical action, patient engagement, and pricing and coverage policies that will try to get us to the best way we can to care for patients, families with opioid addiction in this country. Now, you've been introduced to the members of the New England CEPAC, which is an independent group that we convene to help look through the evidence and to hear testimony and to think and to deliberate in public on these issues. A brief background on ICER, which is the academic secretariat for this program as well as its convener. So as an independent not-for-profit research group, we keep an updated pie chart of our funding sources. Here you can see that 78% approximately is coming from nonprofit foundations. The primary funders there are the California Healthcare Foundation and the Laura and John Arnold Foundation. We have a separate program that we call our Policy Summit that we run with leaders from the manufacturing community and from payer community. So we do take contributions for that separate program from them in essentially equal proportions, and that money is not used to support the research on these kinds of topics. The report today that serves as the backdrop for the discussion was developed over a 7.5-month period. And it starts with a really intensive scoping phase where our staff reach out to clinical groups, to clinical experts, to patient groups and individual patients, and to manufacturers and payers, really trying to understand what are the key questions, where are the road blocks in terms of understanding the evidence, and what matters most to patients and their families as we try to look at the evidence that we have. Then the ICER staff does an internal review of the existing published literature. We invite even academic and confidence contributions from manufacturers to try to make sure we have the best evidence possible. And we create a cost-effectiveness model to try to use the existing data we have to look over the long term, to try to understand the best we can about how the impact of different treatment options affects the longer-term outcomes for patients, their families, and the costs associated with that. This process undergoes public comment and revision and touch points with patient groups and manufacturers at several points. And then we have actually separate expert report reviewers, and they were Dr. Sarah Wakeman, who is a medical director of the Substance Use Disorder Initiative at the Mass General Hospital here in Boston, and Dr. Ruth Potee, who's the medical director and chair of the Department of Medicine at Bay State Franklin Medical Center and works in the House of Corrections in the Franklin Recovery Center in Greenfield, Massachusetts. So they're the reviewers. How is the evidence structured in the report? And in a way, the way that the evidence is structured matches the way that the deliberation today will proceed. So first, we hold as a common goal with all stakeholders in the system that we really do want sustainable access. We want a healthcare system that can guarantee sustainable access to high-value care for all patients. And the evidence and thinking to get us there, we believe, can be viewed through two different lenses. One is the long-term value for money, thinking again about the longer-term effects and how that plays out for patients, families, and the system. And sometimes there's tension between that long-term value and the ability of the health system to afford things in the short term. So our report has those two different buckets, separate, but in a report where they can be looked at by policymakers. Now, long-term value for money itself is a complex concept, and our report breaks it down into four different buckets. The first is a clear look at the evidence on the comparative clinical effectiveness of different treatment options. Then, as I mentioned, there's a look at the incremental long-term cost effectiveness. We also have sections of the report, and you'll hear both discussion and voting around other benefits or disadvantages and contextual considerations. As you'll see, these are concepts that there may be important aspects of value that aren't captured in the clinical trials, aren't even captured in the cost-effectiveness model, even though we always want to build things in when possible. So we'll discuss whether there are or aren't important other potential benefits or disadvantages, and there are always contextual considerations that we feel merit important consideration by policymakers. Short-term affordability, there is a potential budget impact analysis in the report that will factor less into the discussion today, but it is there for policymakers to refer to. All right, so just briefly for the agenda again today, we'll start off after my remarks with the presentation of the evidence, starting with Dr. Rainer Banken, and then we'll move following that to two separate sessions of public comments, first from manufacturers and then from the public representatives. There will be a lunch. Lunch for the audience members will be here in the hallway, just outside this conference room. And we'll reconvene at 1 o'clock for further deliberation and the specific votes on clinical effectiveness and value, followed by a short break and then the policy roundtable. And the policy roundtable, again, will involve our clinical experts. Very much hope our patient representative will be here. We'll have other policy experts, including payers and people who've been thinking about the application of this evidence in the correctional justice system and elsewhere. We'll also be joined there as well by manufacturer representatives. So thank you for being with us today. It's a very important topic. It's a topic on which I think the evidence is challenging, but the larger picture of the challenge for the country remains of critical importance, so we hope to contribute purposefully to that dialogue. With that, Dr. Banken.
So I'm going to talk about the clinical effectiveness review. We are working a team. These are the names of the persons in the team who did the evidence review, supported by the rest of the ICER team. We have no conflicts of interest relevant to this the topic of this report. Steve mentioned the importance of the opioid epidemic, the importance of the opioid use disorder. So in 2016, 2.1 million people in the US suffered from OUD, and indeed 116 Americans died every day from opioid-related drug overdoses. So the opioid epidemic is a nationwide public health emergency and has been declared as such, that had decreased overall life expectancy in the US in 2015 and 2016. It's very important to understand that OUD is a chronic condition. It is a disease. And it has frequent relapses that require long-term treatment. So it should be considered as other diseases needing long-term treatment. It's not only an epidemic of deaths, it is also an epidemic of suffering. I think many of you may know somebody in their surrounding who had this disease, who was affected by this disease. There are lots of citations in the media all over the place talking about what is currently happening in the US. So it's devastating patient lives. It has fatal overdoses, devastating families, communities. A word on terminology. Steve mentioned that the report in 2014 was on addiction. Indeed, it was about addiction. But the word that was being used was dependence, because that was the official word in the DSM-3 and DSM-4. Now we are talking about OUD, opiate use disorder. That's defined in DSM-5 by impaired control, social impairment, risky use, increased tolerance, and withdrawal. MAT, we know it's about medications being used to treat opiate use disorder. Very often it stands for medication-assisted treatment. We got some comments that it's not really the medication that's assisting, it's the psychosocial support that is assisting the medication. That's why we decided in the scoping phase to call this medication for addiction treatment. We don't have a cure for the disease, so the aim is to be in the state of recovery, with its multiple dimensions. Recovery can be a state of no use, or abstinence, but it can also be present with reduced use or even continuing use as long as the patient is able to control the use and to control the harm that it creates. A relapse, like any other disease, it's a relapse of the disease. So it involves loss of control, but as you will see, there are different definitions about relapse. So in the studies, relapse is often being used for an operational division of urine tests and use questionnaires. When you see the word relapse today, it's mostly about this operational definition. Management, there are variable paths to OUD, and there are variable paths to recovery. There are also very often some psychiatric comorbidities, depression, post-traumatic stress disorder, and personality disorders. The MAT, it's at the center of the treatment, even if not everybody needs it. It diminishes morbidity and mortality. There is an important question of access, an important gap between the need for and the availability of the treatment. There is also high prevalence of OUD in inmates with a lack of access to MAT. About 20% of inmates have been using regular opioids before being incarcerated. It's a long-term treatment. It can be for a lifetime. When we are talking about MAT, we are talking about substances that have been approved by the FDA for this purpose. So you've got three substances. We've got methadone, which is an agonist. An agonist stimulates the same receptors in the brain as opioids do. We have a very long experience with methadone. It has been around being used since the 1960s, a very strong evidence base. It's being used for withdrawal and maintenance, but due to its abuse potential, it's been classified as a Schedule II substance in the CSA, and its use is limited to regulated treatment programs known as opioid treatment programs. Buprenorphine is a partial agonist, meaning it's also stimulating the same receptors, but with a threshold effect. It's used for withdrawal and maintenance. Its abuse potential is less. It's a Schedule III substance, so it can be used in doctors' offices with a waiver. So when you hear the term office-based MAT, we are talking about buprenorphine. And there is also naltrexone, which is an antagonist. So if it's blocking this receptor, it can only be used for maintenance therapy after prior withdrawal. Withdrawal, sometimes people call this detox, but I think it's a better term to use, withdrawal of opioids. It does not diminish craving. The other two substances, they regulate the brain chemistry because the brain circuits are changed with the addiction. So by being agonists, they're able to normalize the brain chemistry, and this has been quite proven. It's very often mentioned, and that's why they also diminish craving. Naltrexone does not have this effect, and it does not diminish craving. It's not regulated, so it is available on general prescription. Oral naltrexone have been used in the past, but the effectiveness is limited due to treatment retention. So for this review, we are talking about extended release medications. So these buprenorphine, naltrexone. There is unfortunately no extended release medication available for methadone. I think it would be great to have it, but there is none. So buprenorphine, we've got Sublocade. It has been approved by the FDA November 30th, 2017, about a year ago. It can be started after at least 7 days of transmucosal buprenorphine. And buprenorphine transmucosal is always used together with naloxone in order to prevent the abuse potential intravenous use. And the dose is about 8 to 24 milligrams daily. Then you have monthly doses. Probofine, it's an implant. It's inserted in the upper arm, inside of the upper arm. It has been approved 1.5 years ago, and it started after 3 months of 8 milligram or less. So there's a problem because the usual dose of effective buprenorphine therapy is above 8 milligrams, more in the range of 10 to 16. After one implant, which lasts for 6 months, another implant can be inserted in the other arm, but then the patient has to go back to buprenorphine therapy. And we have got the naltrexone-based extended-release formulation, which is Vivitrol. It has been approved for alcohol use disorder, but for OUD it has been approved in 2010. The challenge is how to get the patient to the state of opioid withdrawal, and you cannot take buprenorphine to get the patient there. Then you have monthly injections for Vivitrol. Population of interest, patients 16 years of older and older, because that's what the population for which most of the extended release formulations have been approved. And it is about these patients who are considered for MAT. So a patient comes into the doctor's office, and they discuss the use of MAT, and where should the patient be directed? There are very subpopulations, and we can speak about that, but this is the overall population who's being considered for MAT, so the question of intent to treatment is very important in the analysis. Outcomes of interest, a very wide range of interest that we're looking for, including social impacts, socioeconomic impacts, diversion, also accidental pediatric exposure. That's something that's very often cited. If you get an injection, there is no possibility the child at home could take the buprenorphine naloxone transmucosal product. We got feedback from patients. MAT is often difficult to access. I think this is important policy questions. This report does not deal with access, but I think it's important to be present discussions of how does this contribute, for example, to the overall access to MAT. There is also a stigma attached to OUD. It should be a disease, but it's often considered to be a moral failure by many. So this influences strongly the availability and the type of treatment that is available in the US. Treatment is not one size fits all. So patients are requesting to have access to a wide variety of different medications. And they're asking equal access to all types of medications. They have mentioned, for example, specifically that for some of them they feel Vivitrol is available much more easily than the agonist therapies. Patient groups consider what is important is daily functioning and well-being. It is not abstinence. And even the FDA has insisted on this point recently and say studies on MAT should consider outcomes related to daily functioning and well-being. When we did our systematic review, we came up with 557 potentially relevant references, and there were 23 references, of which 18 focused on comparative clinical trials, 2 were in observational studies. And these references corresponded to 11 trials, of which 5 were identified as key trials for these drugs. So these are the key trials, 1 for each of the buprenorphine long extended release products and 2 for Vivitrol. Most of them were non-inferiority trials. Treatment duration, 12 to 24 weeks. Something important to consider, as this is a chronic condition. The types of outcomes were around different definitions of responders or relapse, which are based on a combination of urine samples and self-reported use to assess the use of opioid substances during the treatment. This is a summary trial of the outcomes. More details, you can find them in the report, in the evidence summary. So as you see, discontinuation, and this is always compared to buprenorphine naloxone, which is the standard of treatment in MAT. So discontinuation, same. Opioid negative samples, the same or mixed. Then you have got 2 columns, responders and relapse. Basically, it's a similar. Those who do not respond, they relapse. So it depends on the definitions and the wording that's used. Responders, CAM 2038, and I think I mentioned it, maybe not. CAM 2038 is not yet approved by the FDA. It's bound to be approved. It's expected to be approved in about a month. So responders about the same for CAM 2038. Relapse, no data. Probuphine, increase in response, no data on relapse. And Vivitrol, increase in response. If you've got specific questions to that, have a look at the tables and we can discuss this if you have any specific questions on that. So it's important to consider for Vivitrol, this is an intent to treat analysis. As I said, the patients being considered for treatment. For Sublocade, unfortunately, there is no comparison to an active treatment. For Sublocade, we only have a comparison to a placebo. and we were unable in this trial. We tried to do an indirect comparison, network meta-analysis, but we were unable to do so because there's too much heterogeneity in the trial. So we couldn't get that way, unfortunately. Otherwise, we could have been able to include some comparison for a sublocate, but we were unable to do so. Other outcomes, in all of the studies we looked at, there is no data on mortality. For health-related quality of life, there is only a bit of evidence for Vivitrol. The same thing for healthcare utilization. There were no data on infectious diseases, functional outcomes, employment-related outcomes, diversion, or accidental pediatric exposure. For the last outcome, there was just one case being reported in the buprenorphine naloxone arm trial in probofin. Harms, basically not a major issue for these drugs. There are details in the evidence summary in tables 5 and 6 on the harms. Potential other benefits and contextual considerations. We're going to talk about diversion. When we're talking about diversion for opioids is a bad thing. When we're talking about diversion for MAT medications, buprenorphine, transmucal products, it is not as clear. I think it's going to be interesting to have some feedback from our clinical experts on that. Because very often, a significant number of proportions, there are no specific data on that, diverted transmucal products are being used for self-medication. They don't get high on that. They get it because they have withdrawal symptoms and they want this something else than the drug itself. By having extended release products, maybe we can have less negative beliefs about opiate agonist therapy, because sometimes people are saying agonist is like an opioid, they're addicted again. I don't think this is appropriate, but sometimes people say this, and if we have this long-acting agonist medications, maybe these negative beliefs will be diminished. Currently, access is limited in part because of the waivers that are being needed. Opiate use disorder, due to its wide prevalence, should be treated in primary care offices. But physicians need these waivers. Maybe there's no need for waivers in the future, something to discuss that's a potential benefit. Prevention of accidental poisoning, yes, it's one of the issues. Doesn't seem to be major, but it's being mentioned. However, there is some significant uncertainty about the magnitude or durability of the long-term benefits of extended release formulations, given that the trials are over 24 weeks only, over 6 months. Another point is the action of Vivitrol cannot be reversed. So a patient being on Vivitrol, if he has an accident, must receive some regional anesthesia. He cannot use opioids for pain management. Controversies. So we are unable to compare the 4 different interventions between themselves. Too different to do any kind of indirect comparison. The trial population. In many of these trials, patients with psychiatric comorbidities were excluded from the trials, despite the high prevalence among patients with OUD. Outcomes, as often there is uncertainty about what the outcomes measured mean for the patient. So you've got data on opioid use, urine samples, questionnaires. We don't have any data on relevant patient outcomes. We received different comments. We were told that increasing access to MAT should be the policy question. We should not compare the medications. I think it's important to compare the medications. Access is a policy question. I think we got the feedback also that people need this kind of information on the extended release formulations. We were told that the issue of diversion has not received sufficient attention. We did not find any data on diversion in the trials, and we need some discussion about sort of diversion versus self-medication and access. also been told that methadone should have been a comparator in addition to transmucosal buprenorphine. As to the regulatory constraints for using methadone, we felt that buprenorphine was a more appropriate comparator, office-based treatment, MAT treatment for patients. That's why we choose buprenorphine as a comparator. So some elements to understand the evidence ratings that are on the next slide. So CAM 2038 is non-inferior to buprenorphine and may add benefit to usual therapy. Evidence for sublocade is limited to one 24-week phase 3 trial compared to placebo. The study population for probufene may not be reflective of the more general population being considered for MAT. One of the main reasons is the 8 milligram level being released by the implant. Vivitrol is definitely the most mature evidence-based experience in treating patients for any of the treatments. The differences between Vivitrol and buprenorphine naloxone agents are due to, at least in part, difference in treatment intent and goals. So these are the ICER evidence ratings that we gave to the trials, to the overall evidence, sorry. I'm trying to find my wording just to explain the do I have it here? Yeah. Okay. So CAM 2038, it's a C, meaning comparable or better, with a moderate certainty of a comparable, small, or substantial net health benefit, with a high certainty of at least a comparable net health benefit. Sublocade, insufficient. Probufene, PI, promising but inconclusive. A moderate certainty of a comparable, small, or substantial net health benefit, and a small but non-zero likelihood of a negative net health benefit. C, comparable, a high certainty of a comparable net health benefit. Thank you very much. Any questions?
Thanks, Reiner. Yeah, I have a question. If you could go back to slide 22. It's the effectiveness comparison summary. So one of the things that I think would be important to know in these, since these are primarily based on either a single or maybe two clinical trials, what were the primary endpoints versus the secondary endpoints in these trials? We have a lot of very mixed data or inconclusive data, and then certain marks of distinction for probufene and CAM 2038. Were they meeting their primary endpoints, or was this a secondary endpoint that just happened to work out in favor of the drug?
Okay. Let's take CAM 2038, for example. There's some information in Table 5 in the evidence summary. So the outcome on a percent of opioid-negative urine samples, that was a primary outcome. Opioid-negative urine samples at specified time points during the trial. The p-values are related to a superiority analysis. The next line, all of them in this p-value column.
So just to clarify, you're saying that the first outcome, the percent of opioid-negative urine samples, was the primary outcome?
There were two primary outcomes for CAM 20. It's very confusing. It really is all different outcomes, different points of time, different ways on how to calculate and combine the urine samples with the questionnaires. So for the CAM 2038, there were two primary outcomes. One was the percent of opioid-negative urine samples, and the other was responders. With the self-report outcome, the second line was a secondary outcome, and there were also some exploratory outcomes being used in that trial. But it's really, you have to go through every line, and if you have got specific questions, maybe you can try to answer this also, but it's... we tried to combine this into the one table and see sort of how does this, what does it mean exactly, all these different outcomes combined in the comparisons. Yes, Claudia.
Question on, again, on the CAM medication. You rated it as a C+, but that was based just on this one phase 3 trial?
Yes. We think there is good evidence on this. It has been submitted, actually, CAM 2038 has been submitted to the FDA, and it has been, they required additional information on the trials. So it's not a new trial, new evidence on the trials. So it was, I think the PDUFA date was in January, now it's in December. Part of this evidence may be related to the fact that the manufacturer wants to be able to use this medication as an initial treatment without any prior transmucosal product. But the populations of the trial were not in that state. They were on opioid withdrawal. So there's a difference between the intended label that the manufacturer wants, and at least maybe the manufacturers can provide some further information on that. But this is sort of, there are some issues around the trial population and the possible indications on that.
I'd also...
a question over there? Yeah. Oh.
I was just going to comment. Hear me?
No.
It's not on.
There we go. Now it's on. I just wanted to comment that part of our thoughts on looking at all this, remember, is that we're talking about injectable buprenorphine versus oral transmucosal buprenorphine, so that to the extent we're not worrying about unexpected new harms, that's a piece of what's leading to the belief about being comparable, plus the trial evidence.
So pregnant women are included in this population of interest? These are appropriate
yes,
for pregnant
we
women?
tried to do a subgroup analysis. That was our intention in the scope, but we did not have any data on this. Currently, for pregnant women, as far as I know, it's methadone that's mostly used. There is some evidence that buprenorphine products, oral products, can be used in this population. There is no information whatsoever on the extended release products.
I can see that I think it's either all the trials or nearly all the trials are attention to treat analyses with large amounts of dropout in both arms of the trial. So conceptually that, I think, might lower the average treatment effect in terms of the difference between the two arms. I'm just not sure. Do you have any advice about how we are to consider that as a methodological limitation of the trials? Because you could plausibly argue that would increase the relative effectiveness of the new medications, but you could also argue the opposite. I mean, and ultimately, we just have to weigh how we extrapolate this to a real-world setting. Do you have advice for us about how to weigh that?
I mean, there are very many different subpopulations. Some people arrive at opioid use disorder through recreational use. Others are directly, especially younger people, moving through heroin. Other people are moving through opiate use disorder. Sometimes people have polypharmacy, different economic backgrounds, so lots and lots of different subpopulations. So indeed, for some patients, some group of patients, one or the other medication could be of interest, and I think we're going to discuss this later on about the clinicians' perspectives on whom they would use different treatments for. But unfortunately, there is no evidence in the recent SAMHSA guidelines, which came out last year. They say we don't have any evidence on, for example, who should be using Vivitrol. So if you have an analysis at a later point in the treatment, the outcomes would be different. We considered overall this population, and with an intended treatment analysis, didn't find any better grip on the issues.
Yeah. Let me also comment on the implications of dropouts in superiority analysis versus intent to treat. So in a superiority analysis, intention to treat is conservative, right? It's assuming that people who didn't get the therapy get counted as if they did. And so if you still show superiority, it's been a conservative analysis, and you can really believe superiority. If you do only an intention to treat in a non-inferiority analysis, potentially that's not conservative. You're more likely to show no difference. Imagine nobody took the drug in either arm. You're not going to show any difference between the two sides. And so you do need, to the extent that you have concerns about conclusions of non-inferiority, if there are a lot of dropouts, it may make it more likely that you'll incorrectly show non-inferiority when there might really be inferiority. So that's sort of the implications of this. If that comes up on some specific trial issue, we can go through it more.
Do we have any questions or comments from our clinical experts, Drs. Nelson or Wright?
Just to follow that last question up, I think on a clinical level, if I look at a trial with a lot of dropouts in this population, I assume that most of those are returning to active use to some degree that's more than when they were out of the trial. That might be the probuphine, the implant trial is a somewhat different population and maybe to a different degree, but I think, at least in my population, I think dropping out of treatment has a high, not 100%, but high correlation with return to use and use disorder.
Yeah, and I also think there's sort of two populations here. There's the ones that won't even start treatment and won't even enroll in a study like this, or maybe not even in a study, but in the clinical arena. They might not even be interested in it. And if you're sort of you're picking the population that's already most likely to benefit because you've excluded all of the ones who have no interest in even participating. And then in that group, you have the dropouts because either they return to drug use, the drug doesn't work, they have adverse effects. So it does become out. And how you differentiate superiority and non-inferiority statistically, I think it is always very, very complicated. And it was chosen in these studies to do non-inferiority. I guess that was a researcher decision. But I do think you are right that we're going to have a lot of dropouts from all of these trials. But if you really want to look at the people who make it through, it's kind of a healthy worker effect, the ones who continue to make it through the trial. If there's benefit in that population, that's great, because we're going to exclude the people who don't want to participate at the inception in the clinical world, right? They're going to make that decision. So, I mean, I think it's fair to look at that population that actually makes it through.
Okay, so if no further questions, I hand over to Varun.
Thank you, Reiner.
Good morning. My name is Karan Kumar. I'm a health economist at ICER, and I led the economic evaluation for this review. I'd like to thank my colleagues Alex Ellis, Rick Chapman, and Sumay Samur, who contributed to the development of the model. We have no conflicts of interest to disclose. Moving to our methods, our objective was to estimate the cost effectiveness of MATs in people diagnosed with and seeking treatment for opioid use disorder. The population entering the model was a hypothetical cohort of adults diagnosed with and seeking treatment for OUD. And based on the trial data, the weighted average age of the cohort was 36 years, with 30% of the cohort being female, and approximately 50% of the cohort illicitly using prescription opioids, while the remainder of the cohorts was injection drug users. We built a Markov model from a US health sector perspective and used a 5-year time horizon. We chose a 5-year and not lifetime horizon because of the high discontinuation rates of these interventions. And in our review of the literature, we found prior published models that use shorter time horizons of 1 or 2 years, but we chose not to use such short time horizons for the base case because they wouldn't take into account, we felt they wouldn't take into account the downstream effects of these interventions. Our model uses a discount rate of 3% per annum for costs and outcomes, and we use a 4-week cycle length. We model life years, quality-adjusted life years, total costs in 2018 US dollars, and incremental results in the form of cost per quality-adjusted life years gained. As mentioned by Rainer in the clinical evidence review, the interventions were CAM, Sublocade, Vivitrol, and Probufene, and a common comparator was sublingual buprenorphine naloxone. All comparators except Sublocade had trial data comparing it to sublingual buprenorphine, whereas Sublocade was only compared to placebo. And hence, our comparison of Sublocade to buprenorphine was reserved for scenario analysis where we had to make certain assumptions for this comparison. For Probufene, the trial data used only one Probufene implant, while the approved label has 2 Probufene implants, and we reserve this again for a scenario analysis. This is our model schematic. We have a 5-state model, 4 alive and 1 dead state. The 2 highlighted states here are when patients are on treatment with MATs, the top left being when patients are on treatment and have concurrent illicit use of opioids, and the top right state is when patients are on treatment and abstain from illicit use. Upon relapse, patients can transition to going off treatment and being on illicit use of opioids. We also included a health state where patients are in long-term abstinence, which is they are off treatment and do not illicitly use opioids. Transition in our model is unidirectional, which means patients cannot transition back to the health state where they came from, and the reason for this mostly is due to a lack of data around such transitions. So once patients, while on treatment and illicitly using opioids based on the efficacy of the drug, they transition to being on treatment and abstaining from illicit use. And from these 2 health states, when they are on treatment, they can discontinue or relapse and discontinue to the off MAT with illicit use of opioids health state. Abstinence was defined by a negative urine sample and self-report of no illicit use, and relapse is defined by a positive urine sample with or without self-report of illicit use. Although opioid use disorder is a chronic condition, we heard from some stakeholders that a small percentage of patients can go into a state of long-term abstinence while they are off treatment, and hence we use certain assumptions and model that as well. Death in the model occurs from all the 4 live health states, and death can be from background mortality, opioid-related overdose death, and from HIV and HCV infections only among injection drug users. Prior to treatment initiation, patients undergo certain initiation protocols based on specific treatments. For CAM and Sublocade, based on success with run-in or induction, they enter the model in the MAT with illicit use of opioids health state, which means that for these treatments, patients need not be in complete opioid withdrawal when starting these treatments. Whereas for Vivitrol and Probufene, based on success with detoxification or being clinically stable, they enter the model in the MAT with no illicit use of opioids health state. For all these interventions, if patients fail these if there's failure in these initiation protocols, patients enter the model in the off MAT with illicit use of opioid health state. Our model is informed by several assumptions, and I've listed only some of the key assumptions here. The full list is in the report. The first is, upon relapse, patients are assumed to return to pre-MAT pattern of illicit use. This basically means prior to entry into the model, if a patient was illicitly using prescription opioids, upon relapse, that patient would continue illicitly using prescription opioids and not injection drugs. Second was opioid-related overdose mortality was only attributed to patients who are illicitly using opioids while off treatment. We heard that MATs have a protective effect on opioid overdose and associated death, and hence we included this assumption. Incidence of HIV and HCV were attributed only to injection drug users in the model, and we included associated costs and disutilities of these comorbidities. And we assumed that 10% of all patients who were on treatment and were abstinent from illicit use for at least 12 months transitioned to the state of long-term abstinence. Looking at key inputs for the model, efficacy was defined by abstinence, and all these efficacy estimates are over the 24-week duration of the trial. You'll notice that for the comparators, although we use a single comparator, the efficacy estimates are different. The reason for this being the trial populations are slightly different, as well as there's a difference in trial design. All these estimates are over 24 weeks, as I had mentioned, and were converted to per cycle probabilities in the model. The same applies to discontinuation rates as well. We use trial-specific discontinuation rates, for which we had Kaplan-Meier curves that were presented in the trials, which we converted and used in the model using specific distributions. You'll notice for Probufene, the discontinuation rate is 0%. So since Probufene is an implant, there really is no discontinuation rate. So for patients who, at the end of the 6-month trial period, who are abstinent from illicit use on Probufene, they are then transitioned over to using sublingual buprenorphine and were awarded the costs and benefits of buprenorphine thereafter for the rest of the model. Health state utilities in our model were sourced from a US-specific survey study that used the standard gamble method to elicit utility estimates. For patients who are illicitly using opioids, they could be illicitly using prescription opioids or injection drugs, and based on this, we attributed utility values. You will notice that patients who are injection drug users have lower utility estimates compared to those illicitly using prescription opioids. We also included HIV and HCV-related disutilities among injection drug users in the model. For drug costs, CAM is an investigational drug and currently has no list on net price. For Sublocade and Probufene, we got the net price from the Federal Supply Schedule. And for Vivitrol, the net price was provided to us by the manufacturer. For a comparator, sublingual buprenorphine naloxone, there were multiple generic options available, and hence we used the WAC. For Probufene, you will notice the annual net price of $3,640. This is the price of one Probufene implant. We also included administration and monitoring costs associated with these treatments. Other healthcare costs were those associated with inpatient admissions, emergency department visits, and outpatient visits. When patients were on treatment and abstained from illicit use, their inpatient and emergency department visit costs were lower compared to patients who are illicitly using opioids, whereas their outpatient visits were higher. The reason for this is these patients have to frequent the physician's office to get these treatments administered. Again, for HIV and HCV-related comorbidities among injection drug users, we included their drug and non-drug costs. Before we go into the results, I want to say that we did not find any appreciable differences in mortality because the length of our model is only 5 years. So we don't report those as the life year results over here. But for reference, the average, the life years for the interventions and comparators was 4.6 years. So moving to the base case results, the CAM versus buprenorphine comparison. Again, since CAM has no price, we don't report its total cost. We did conduct threshold analysis where we conducted these analyses for price at thresholds of between $50,000 and $150,000 per quality. We see here that CAM has marginally more qualities than its comparator. In the Vivitrol and buprenorphine comparison, Vivitrol has higher costs and marginally fewer qualities. Although the trial data showed that efficacy, the discontinuation rates between Vivitrol and buprenorphine were fairly similar, Vivitrol had a higher rate of failure in detoxification, and this is what is driving these results. Comparing Probufene and buprenorphine naloxone, we see that Probufene has higher costs and marginally more qualities, resulting in an incremental cost-effectiveness ratio of $265,000 per QALY. We conducted one-way sensitivity analysis and found that these results were being driven by the incidence of HCV infections, treatment costs, and treatment discontinuation rates. We also conducted probabilistic sensitivity analysis where we simultaneously varied multiple inputs in the model over 1,000 simulations. And for Vivitrol, we found that over 1,000 simulations, approximately 99% of the simulations produced results where Vivitrol had higher costs and fewer QALYs. For Probufene, approximately 77% of all simulations produced results where Probufene had higher costs and more QALYs. In our scenario analysis comparing Sublocade to sublingual buprenorphine, we conducted two threshold analyses, one for effectiveness and one for price. For effectiveness, we assumed Sublocade's federal supply schedule price and favorable assumptions of 100% adherence and abstinence, and found that its cost effectiveness went only as low as $215,000 per QALY, still well above the $150,000 per QALY limit. For price, we assumed Sublocade to have the same efficacy and discontinuation rate as CAM, and found that it had to be priced at approximately $400 for a monthly dose of 300 milligrams for it to reach its threshold of $150,000 per QALY. And again, as a reference point, its current federal supply schedule price for the monthly dose is $1,200. We also conducted other scenario analyses, one from a modified societal perspective where we included the costs of lost productivity, criminal justice, and incarceration. One scenario where the patient cohort was only injection drug users, which means in this scenario there would be lower utility estimates and higher costs associated with treating comorbidities of HCV and HIV. We excluded the pre-MAT initiation protocols, basically saying that there was 100% success with induction or detoxification prior to being treated with any of these interventions. And finally, aligning with Probufene's FDA label, we included a scenario where 2 consecutive implants of Probufene were used in patients and associated costs and benefits of the 2 implants were included in the model. We found that the results were directionally similar to the base case across all scenarios except in 2 instances. The first was in the comparison of Probufene and sublingual buprenorphine. So from a societal perspective, Probufene was a dominant strategy, which means that it had lower costs and marginally higher QALYs. Again, in the base case, it had higher costs and more QALYs. In a scenario where we assumed 100% success with detoxification for Vivitrol, it produced an incremental cost effectiveness ratio of approximately $1.1 million per QALY. Our model has certain limitations. The first is our model does not allow patients to cycle through different MATs or retreatment, and although this is something that is seen in the real world, we have no estimates around this. We could not include estimates around diversion or switching in the model due to a lack of robust data on these estimates. And our model does not account for different levels of illicit use, and we know that in the real world, once patients relapse, they have different levels of use, and this will impact costs as well as their quality of life. But we weren't able to include this in our model, again, due to a lack of data around these estimates. And finally, all the data that we have is on 24-week trials, which we had to extrapolate for over a 5-year time horizon. We got several comments. I've only listed some of the key comments here. The first 2 I discussed in my previous slide. The first was around diversion. The second was around the various levels of illicit use. The third comment is saying that we should consider different patient populations for the different interventions. And to this, we'll say that the key trials had slightly differing populations, and although we used the same comparative, we used trial-specific estimates in our model. So in summary, our interventions show only marginal changes in QALYs relative to the comparator, with CAM showing marginally more QALYs, Vivitrol showing higher costs and marginally fewer QALYs, Probufene showing higher costs and again more qualies, and Sublocade, even under favorable assumptions, not reaching the threshold of $150,000 per quali in the scenario. And once again, findings were driven by the intervention's adherence rates, costs, and the incidence of HCV infections. Thank you. I can take questions now.
Thanks for your presentation. Two questions, if I may. The first is in regard to the ICERs for the comparators with generic buprenorphine daily use. Concern that using trial data to estimate the efficacy of buprenorphine may be different than real-world effectiveness of buprenorphine daily use, which may be more sporadic or at least have more issues with adherence on a day-to-day basis. And I didn't see that in a sensitivity analysis in a way that might help assuage that concern. The second question is about the model structure and the health state that permits people to be in a state of abstinence, but yet not to progress to relapse from that health state. So maybe just some decision-making around that model structure decision. I'd be interested in hearing.
Yeah.
Thanks.
So to answer your first question around what we did was we did conduct sensitivity analysis for the abstinence, the efficacy, as well as the discontinuation rates, and we have tornado diagrams that we did as part of a one-way sensitivity analysis that showed that in spite of varying these across the ranges, we still did not find any of these interventions to be cost-effective. But I do agree that including real-world estimates around sublingual buprenorphine's efficacy or long-term discontinuation rate will maybe show differing results, but we didn't find too much data around its real-world data around this. But if there was, we'd definitely be happy to model that. And I'm sorry, can you go over your second question again?
Sure. It's about the health state in the model that permits people to transition to essentially abstinence after MAT.
Right.
And from that health state, they can progress to death, but not to another state of MAT use. Wondering about the decision-making around that.
Again, this was something we wrestled with during the course of this review, and we acknowledge that once patients go to a state of abstinence, they can move back to illicit use, even from long-term abstinence. But we just were not able to find any data around this, and instead of making assumptions around this, we just said that we will make transition unidirectional in the model.
Thank you.
I also had a question about thank you so much for all the presentation, the rigorous work. Okay. I just had a question about the structure of the model as well. So my understanding is that the way that HCV and HIV infection are modeled for active illicit drug users is through the utility weight on that health state. But then there's also, and I think this is particularly relevant, right, because the base case is 36 years old. The primary mechanism, I would think clinically, of a real difference is, and we see this clinically, is a death, an early death from other types of infections that are not viral, like so bacteremias or endocarditis. I mean, as clinicians, I'm a cardiologist, so it might be that I'm biased, but I perceive that would be a mechanism through which you really have a difference in quality-adjusted life years in the comparison groups. So how is that modeled? If I've understood this correctly, HIV-HCV infection were modeled by a decrement in the utility weight on that health status, but how do they transition? Is it a higher rate of mortality?
So we did find estimates around mortality, with HIV and HCV infections among injection drug users specifically, and we have included those in this model. So once patients contracted these infections, they'd go into HIV and they'd have the costs and disutilities of being in HIV and also being treated with it. But we'd also given them mortality estimates once they did have HIV or HCV.
Got it. So, but then what would happen if how was bacteremia or endocarditis modeled?
We didn't model bacteremia or endocarditis specifically.
Okay. So it didn't affect even the probability from transitioning from illicit use health status to a mortality health status.
Yep.
So remember, there's an estimate on transition rate to mortality, which is higher if you're using illicit drugs. So it's modeled, it's baked in to the transition probability of death.
Got it.
It's just not pulled out as a particular way of dying.
Got it.
Right? I mean, obviously, overdose is another way that you die if you have ongoing opioid use disorder.
Okay. So that seems to be reassuring to me that the multiple mechanisms of mortality for illicit drug use are modeled insofar as it affects the transition probability from one health status to mortality.
Yes.
Got it. Thank you.
So could we go back to the slide on drug costs? And I remember reading this in the report, but I find myself with a lack of clarity. So Probufene is modeled on one implant, but that's really only 1/2 of a year. Is that correct?
Yes. Yes, it's only for the 1/2 of the year. So, and for the, beyond the first 6 months, for the patients in the Probufene arm, those who are abstinent from illicit use, they get the costs and benefits of sublingual buprenorphine.
Any other questions from the panel? Steve?
Just another question on price. And the current pricing of the generic SL buprenorphine was sustained throughout the 5 years?
Yes.
Jason? I also just had a question about about one of the sensitivity analyses. So as I understand it, what you did with Sublocade is that you varied the input assumptions of percentage adherence and of abstinence.
Yeah.
But then even with those varied assumptions, the incremental cost effectiveness ratio didn't go below $215,000.
Yes, in the best case scenario, you can call it that, where we assume 100% adherence and abstinence, which means everybody would transition to being abstinence pretty much in the first cycle. Even then, we found that the cost effectiveness ratio would not go to $150,000 per quality.
Got it. So then presumptively, if you varied the assumptions in the model, so you went to 99%, 98%, and lower, the incremental cost effectiveness ratio went up.
Yes.
Okay, so that's the best you could do with those assumptions.
Yes, that's the best you could do.
Got it. Thank you.
I am educable. Gene, I just wanted to add on to your question. It may be obvious to you, but one of the reasons that Probufene has an incremental cost effectiveness ratio, and then in the modified societal perspective, it's dominant, is because in a way, over 5 years, you're considering the costs of 1 year of Probufene and 4 years of the cheapest alternative. So if patients were to switch from Probufene to an injectable, extended release form, then the cost effectiveness would be very, very different. So I just wanted to make sure that was clear, that there's a steep step down in the cost after 1 year, so that over that 5-year period, the Probufene cost effectiveness in many ways is, it's very strongly affected by that assumption that they would go to oral buprenorphine and naloxone.
But, excuse me, Stephen, but isn't it after the first 6 months because they're only getting one implant?
I thought it was 12. Was I wrong?
They get only one implant, and
it's
that's
just
for the
6
first
months.
one. Yeah, 6 months. Yeah.
There is a scenario
where we do.
But there's another scenario.
Yeah, we have a scenario where we give 2 implants, so 12 months.
So at this point, I'd like to ask whether our clinical experts have any comments on the cost effectiveness analysis.
I think the mortality rate in this population is a moving target. So overdose mortality is based not only on the potency, but on the variability of potency in a given drug supply. So this is part of why you can see these rapid spikes in overdose rates and then a stabilization of overdose rates that has nothing to do with what we as health professionals are doing, but just the self-regulation of the drug supply by its market. So I think, and then the other problem is that even if you can model that changing overdose rate, the trials are not sufficiently powered to look at the effect on overdose. And this is, on a clinical level, I think why some of us who are very focused on overdose mortality as our primary clinical outcome that we're interested in are more hesitant about Vivitrol in the concern that, again, is not proven by trials, that mortality might be higher once it's stopped. So there's a bunch of moving assumptions that are based on the epidemic that you could think of, if you compared it to infectious disease modeling of a very rapidly changing infectious agent whose characteristics versus the drugs themselves are going to be variable.
Well, thank you. So at this point, we'll transition to the manufacturer comments and discussion section of the morning. I'd like to invite the manufacturer